Good afternoon, everyone. We'll call this meeting to order of the Health and Human Services Finance and Policy Committee. Today's date is February 21st, 2022. First up today, we have Senate File 2302 brought to us by Senator Nelson. Senator Nelson, if you would like to bring your bill before us and then tell us what's in it.
Oh, thank you, Chair Utke and members, for hearing Senate File 2302 today. Mr. Chair, I would like to move Senate File 2302, and I do have the A1 amendment.
Okay, thank you, Senator Nelson. And I think, why don't we take, do you want to go through your bill first, and then we will bring the amendment back up and have Mr. Albrecht dig into it, because the amendment is the fiscal note. Yes,
thank you, Mr. Chair. I'd be glad to speak to the bill first. And before I begin, I would like to thank our bipartisan co-authors. This is the Nurse Licensure Compact authorization. Senator Eakin, Senator Benson, Senator Johnson, and Senator Rosen. Members, Senate File 2302 would authorize Minnesota to enter into the Nurse Licensure Compact. The Nurse Licensure Compact increases access to care, protects patient safety, and reduces cost while supporting state-of-the-art healthcare delivery. The Nurse Licensure Compact allows registered nurses and licensed practical vocational nurses trained to the national standards to have one multi-state license, with the privilege to practice in their home state and other national Nurse Licensure Compact states without obtaining additional licensure. Oh, I think the phone is on. Sorry.
I could hear the buzzing, and I'm looking around here, but now we know whose it is.
Okay, this new hybrid testifying is just a little bit different. So joining the Nurse Licensure Compact is a smart change that benefits both patients and nurses in Minnesota. I'm going to immediately turn it over to my testifiers to describe why this is important. I'll have a few follow-up comments a bit later, and then we'll turn it over to that A1. So, well, Mr. Chair, our first testifiers.
Senator Nelson, as long as you're going to go to testifiers, maybe we should attach the A1 at this point then. You've got your introduction done. If you want to move the A1, then we will get information on that.
Oh, thank you, Mr. Chair. Members, I would like to move the A1, that's Senate Council 2302-A1. And as the chair said, this is the appropriation for the enactment of authorizing Minnesota to participate in the Nurse Licensure Compact.
Okay. Thank you. And members, we're going to go to Mr. Albrecht to, it's a fiscal note, and he's going to further explain a little bit about what's included in it before we adopt it. Mr. Albrecht.
Mr. Chair and members, and I'm not on Zoom, so I apologize for that. The amendment includes amounts from the fiscal note from the 2017-2018 session for Senate File 3305. The amount of $157,000 is the amount that the Board of Nursing needs to set up and implement the Nurse Licensure Compact, and that's the part that has the ongoing cost of $6,000. And I'm looking at page 2, sort of at the top there, where it breaks apart the expenditures from the revenue. And in this case, on number 2, the major cost factor that's shown on the front page results from a loss of revenue, and that is $378,000 per year after it's implemented.
Okay, thank you, members. Any questions concerning that? Okay, we will. All those in favor of the A1 amendment signify by saying aye.
Aye.
Aye. Opposed? Amendment is adopted. With that, Senator Nelson, you can start to call on your testifiers.
Oh, thank you, Mr. Chair. First, I'd like to have Tony Narr, the Advocacy and Policy Chair for the Minnesota Organization of Leaders in Nursing. And Mr. Narr is here today. Dr. Narr. Yes. Mr. Chair, do you have a testifier sheet for signing up here? We usually do, but I did not see one today.
I think they'll get us a sheet and get it
Thank
up
you
to
for
you.
getting us on track, but you can start. Once the chair
Thank you.
recognizes you.
Glad to have you. Please introduce yourself for the record, and then please continue with your testimony.
Yes, Senator Utke, committee, thank you for having me. My name is Tony Narr. I am the Policy and Advocacy Chair for Minnesota Organization of Leaders in Nursing. We are a group of a little over 300 leaders, nurse leaders across the state of Minnesota, representing nurses from the far north reaches all the way down to southern Minnesota. We are here in strong support of the Nurse Licensure Compact. We've been honored to support this legislation for the 11 years that it's been here at the Capitol prior to this. First and foremost, we're extremely proud of the wonderful care that nurses in Minnesota provide. The Nurse Licensure Compact is essential for helping nurses provide that care outside of the state of Minnesota to support patients that move into Iowa, Wisconsin, North and South Dakota. Secondly, we are watching the changes in healthcare. So nurses are providing telehealth, they're providing remote health, they're providing EICU care. All of these things take our patients outside of Minnesota. We think it's critical that we support the nurses so that they can provide that care and continue to stay with their patients beyond the Minnesota borders. Secondly, when we started this, there were only about 19 states that had signed on to the Licensure Compact. We're up to 39 states. So to continue that long tradition of leadership in Minnesota, we think it's important that we get on board and support this so that we can continue to provide care to patients in all 39 states that are in here. Finally, we've seen this last 2 years through the pandemic how important it is that we have flexibility and that we allow nurses to move to support patients where the need arises. On a month-to-month basis, we've seen different hotspots across the country. The Licensure Compact helps support nurses to move to where patients need them most. And so this will take legislative burden and administrative burden out of the nursing practice and allow us to focus on what we need to do most, which is focus on our patients and get care to the patients where they need it. Again, thank you very much for having me. Minnesota Organization of Leaders in Nursing asks that you please support this bill.
Thank you very much. Next up, we will hear from Dennis Stacy, and then following will be Dominic Paul. And for everyone that's testifying, and Senator Nelson, we will go through all of the testifiers for the bill first, and then we will take questions and comments from the members, and then we will go to those in opposition and do the same thing there. So, Mr. Stacy, welcome to our committee. Please identify yourself for the record and then proceed with your testimony.
Thank you, Chair Utke and members, for the opportunity to testify before you today. My name is Dennis Stacy, and I've been a nurse for 13 years, with 10 of those years being at Mayo Clinic. Currently, I have the privilege of managing our home dialysis program, where we care for patients who live within 150 miles of Rochester. In order to provide care to our patients needing dialysis, my staff are licensed in Minnesota, Wisconsin, and Iowa. These staff are then required to maintain these separate licenses during their dialysis career for patient house calls and telemedicine. As you're aware, telemedicine has been an increasingly important modality of care. While the COVID-19 pandemic has been challenging on many fronts, the ability to provide care virtually was frequently utilized by our patients and allowed our vulnerable patients to convalesce in the comfort and safety of their homes. This allowed for continuity of patient care and supported positive patient outcomes. The utilization of virtual care for our dialysis patients increased exponentially during the pandemic, and we know the demand will continue in the future. Beyond the pandemic, if a patient chooses to travel, their current care teams may not be able to provide continuous care if travel occurs beyond a state where the nurses are licensed. This leads to patients needing to find alternative care options. With joining the Nurse License Compact, my staff would be able to maintain the personal care they have fostered with their patients. I also manage the downtown outpatient dialysis clinic in Rochester, which is part of an 8-clinic dialysis program based in Rochester. We have sister clinics in Onalaska, Wisconsin, and Decorah, Iowa. As urgent staffing needs arise, if a member of the team is not licensed in either of our bordering states, we are unable to assist our colleagues to meet the needs of our patients. Joining the Nurse License Compact would allow our teams to support each other and minimize disruptions in care, especially during our current trying times. Thank you for the opportunity to speak with you today and for your consideration of this important legislation.
Thank you. Next up, we have Dominic Paul. Welcome to our committee. Please identify yourself for the record and continue with your testimony.
Certainly. Chairman Utke, members of the committee, thanks so much for this opportunity. It's a real privilege to be with each of you this afternoon, and appreciate you all taking the time to hear this legislation. And so my name is Dominic Paul. I am a Minnesota born and raised nurse, and currently have the privilege and opportunity to work as a nurse manager for virtual care at the Mayo Clinic in Rochester. Throughout the course of the COVID-19 pandemic, we have learned much about the benefit and need for our state to join the Nurse Licensure Compact. Today, I have the privilege of leading 2 distinct nursing teams that can significantly impact the care of patients both in Minnesota and across state lines. Our remote monitoring team has cared for thousands of patients diagnosed with COVID-19, both in our state and beyond. In Minnesota, we have seen over 7,500 patients enrolled in this program, and in states beyond Minnesota, we have enrolled over 5,800 patients. Patients that in the absence of licensure, we would not have otherwise been able to help. The impact of this program has been astounding, and this is just one of many remote monitoring programs that we continue to offer our patients. In a study that will soon be published in peer-reviewed journals, patients that were engaged in this COVID-19 remote monitoring program were significantly less likely to experience a hospitalization. And when hospitalized, these patients experienced fewer total days in the hospital and fewer total days in the ICU. This program and others like it continue to provide a care delivery method that reduces healthcare costs, provides timely detection of a need for intervention, and enhances the engagement of patients in their care. Additionally, as digital solutions and virtual care team models have continued to expand and mature in healthcare, we have seen the impact of our virtual nursing teams, the impact that we can have across state borders. Embracing the compact allows our virtual nursing teams to continue to provide immediate support and oversight to other hospitals experiencing staffing needs and fluctuations in patient acuity, things we've seen throughout the pandemic. Furthermore, the compact removes delays in patient care that are experienced when staffing resources cannot be quickly reallocated to meet patient care needs beyond our borders. To provide an example of this, I'm currently pursuing licensure in 4 different states beyond the state of Minnesota. My team members also need a licensure in those states. Between the press conference we had this morning and the time now, I attended to 6 different emails for 6 different staff members needing licensure in different states that do not include the state of Minnesota. That sort of red tape is removed with the Nurse Licensure Compact. Today, a patient could travel to the state of Minnesota and without any additional nursing licensure, I could provide exceptional care for that patient. On the flip side, if I were to travel to that patient either physically or virtually through some sort of digital solution or virtual care sort of engagement platform to that patient's home state of residence, I would not be able to provide that same exceptional level of care without having licensure in that state. That licensure process is burdensome and can take, in some instances, months for approval. The contrasts of this scenario continue to frustrate me, and we must remedy this gap with the compact. Minnesota has always been a leader in healthcare, and it requires our continued efforts to remain a leader. Joining the compact will ensure we continue to lead in care delivery across state lines. A vital change as healthcare continues to expand access through digital tools and virtual care team models. Our patients deserve to have the same care, and our nurses deserve to have the same opportunities despite their current zip code. Ultimately, failing to join this compact is failing to take a necessary step closer to ensuring equitable access to the best available care. Accounting for all this evidence, my ask to each of you, that is, if you were to be in opposition to this licensure compact, is that you would please consider rethinking your position. It is imperative that each of you would choose to support our state in joining the Nurse Licensure Compact. Our nurses, our patients, and our loved ones are all deserving of our advocacy in this way. Thank you all for the chance to discuss this with you, and please know that I would invite the opportunities to continue this conversation. Thank you all.
Thank you. Next up, we are going to our Zoom connection with Rebecca Foch. I hope I got close on that last name. Welcome to our committee. Please identify yourself for the record and then proceed with your testimony.
Thank you, Chairman Uski, and thank you, members of the committee. My name is Rebecca Foch. I am the Director of State Advocacy and Legislative Affairs for NCSBN, which is the National Council of State Boards of Nursing. And we are also the drafters of the Nurse Licensure Compact. So I wanted to take my time today to explain to you how the compact works and why it's extremely safe. So first and foremost, I know that Spencer already talked a little bit about this, but I wanted to say it just once again that the compact works very similarly to your driver's license in that you have a license in the state that you reside in, and then you're able to use that nursing license in any of the other compact states without having to get any additional licensure. There are 11 licensure requirements needed in order to obtain a multi-state license. First and foremost, a nurse who is applying for a multi-state license in Minnesota needs to meet the home state's requirements for licensure. So whatever Minnesota is currently requiring for a nurse to be licensed in Minnesota, those same requirements would stand if the nurse was applying for a Minnesota multi-state license. Additionally, the other requirements are requirements that most, if not all states already require, including passing the NCLEX, which is the national examination that all nurses must pass in order to practice, graduating from the board-approved nursing school, and obtaining criminal background check. There are safeguards in the NLC, one of which is the requirement for information sharing between boards of nursing regarding investigations and disciplinary matters. And additionally, as I had said, the criminal background check is required in the compact legislation for any nurse that is applying to obtain a multi-state license. I should also point out, I think it's important to remember that discipline is extremely low with nurses. Most nurses are competent, great nurses. Currently, the discipline rate is 0.2% of nurses. And there is no differences in that discipline rate between compact nurses and non-compact nurses. That's really important to remember. There are currently 37 states in the compact, 2 territories, and there are 7 states with pending legislation. The compact has been in operation for 22 years. There are many healthcare occupations now that have their own compacts, like physicians, physical therapists, EMTs, school counselors. It expands every year. But the Nurse Licensure Compact was the first of the healthcare compacts. And it has, over those 22 years, the NLC has proven safe and effective to offer greater nurse mobility and better access to care for patients. Thank you.
Thank you. Next up, we have with us Rochelle Rindles. Welcome to our committee. Please identify yourself for the record and proceed with your testimony.
Good afternoon, Mr. Chair. I want to thank you and the committee members for the opportunity to speak. My name is Rochelle Rindels. I'm the Vice President of Nursing and Clinical Services for the Good Samaritan Society. We currently serve 22 states with 158 skilled nursing facilities. And in the state of Minnesota, we care for 2,629 residents within our facilities every day. We also employ nearly 3,000 nurses across our footprint. Living and working in Sioux Falls, South Dakota, I work with and direct nurses from many different states, including our neighbors and colleagues in Minnesota. The pandemic has made partnering and working across state lines ever more essential as COVID-19 outbreaks call for immediate staffing changes in all types of healthcare settings. To address the need for immediate staffing and continuation of care for elderly residents, the Good Samaritan Society created an enterprise rapid response pool of RNs, LPNs, and CNAs. These nurses are assigned to crisis locations that are a COVID-19 outbreak or other crisis contributing to staffing needs. The rapid response nurses are discharged to a location within 48 hours of the request. Requirement of a single state nursing license in Minnesota creates an inability to provide adequate care to elderly Minnesota residents, as rapid response nurses are delayed due to licensure requirements. We are able to immediately place these nurses in 18 other states across the organization. The COVID-19 pandemic created a staffing pandemic for the healthcare industry, which long-term and senior care providers are not immune. Today, the Good Samaritan Society utilizes nearly 700 nursing agency positions across our footprint, around 13% of our nursing workforce. Requirement of a single state nursing license in Minnesota creates a barrier to providing necessary care to frail elderly residents across Minnesota. Narrowing the pool of available agency nurses only leads to an inability to partner with Minnesota hospitals and contribute to the decompression and throughput of acute care patients needing a skilled level of care. Recently, the long-term care imperative of Minnesota produced a 2022 workforce study stating 78% of nursing facilities are restricting admissions due to the staffing crisis, and that 20% of registered nurse positions across the state remain unfilled. As a long-term care provider in multiple states, I know our residents don't see the state on the nursing license. They see the compassionate face of their nurse. Care should not be delayed due to single state licensure requirements. Please support and pass SF 2302 and protect care for our residents and provide staffing relief for frontline workers. Thank you, Mr. Chair.
Thank you. Next, we have with us Kelly Hagan. Please identify yourself and proceed with your testimony.
Thank you so much, Chairman Utke and members of the committee. Thank you for the opportunity to testify in front of this committee. My name is Kelly Hagan. I am the Vice President of Nursing at Sanford Bemidji Medical Center, a not-for-profit regional referral facility serving northwestern Minnesota. As a nurse leader with responsibility for patient care and oversight of nursing and clinical practice and services, I urge you to support the adoption of Minnesota as a nurse licensed compact state. I'm certain that you've all seen the facts that support the why and why this is necessary. From my personal perspective, I have seen the constraints of being in a state that Minnesota did not recognize the license for on how I personally was unable to provide leadership and oversee nursing practice and patient care because of a delay in my ability to obtain a Minnesota license. When a nurse in Laverne, Minnesota calls our employee health nurse in another state to report a bloodborne pathogen exposure, an injury, or some other employee health matter, the nurse answering the call, providing direction and triage, must be licensed in the state of Minnesota to provide that oversight. The lack of a nurse compact licensure agreement in Minnesota impacts how we are able to build our pipeline of new nurses. As nurse leaders, we know how badly we need future nurses and how important their education is. Many of us are clinical sites for those nursing students. Nurse educators are required to hold nursing licensure in other states as well as Minnesota when working with students. The Nurse Licensure Compact would allow nurse educators the ability to provide care and lead educational opportunities across state lines without the cost and burden of additional licenses. At Bemidji State University, for example, if a nurse educator provided oversight for students in North Dakota, the faculty member must also hold a North Dakota nursing license at the behest of Minnesota. We've had delays for traveling nurses coming in from other states who have been badly needed to provide care in our facilities. MB, a critical care RN, was due to start on our critical care unit. She was delayed by a week because of a delay in obtaining her Minnesota license. There was a glitch and a hang-up. This may not sound like much when written in this testimony or said quickly, but imagine when you have gaps in staffing coverage and you are relying on this person to provide care to our critical patients, our sickest patients, and support for a constrained nursing workforce who really are relying on that traveling nurse to come in and add to the bench strength of a unit. When critical care is really not optional, we cannot close beds, patients will die. So by holding up a license, we really are putting things in a difficult position. Joining the compact would streamline our recruiting processes, enhance and support training of our future nurses, allow flexibility for faculty and nurses working in a variety of states and care settings. It would increase access to care and reduce costs while protecting patient safety and supporting flexible care models in modern healthcare delivery. To amplify the importance of Minnesota joining the Nurse Licensure Compact, I want to relate that this is long overdue. We need the flexibility and ability to recruit and onboard nurses from across the country in a timely manner. In addition, Minnesotans need new ways to access care. Nurses are practicing in many more modalities, such as telehealth or snowbirds for those who live in other places or other places on a temporary basis and want to keep them connected to their physicians, to their nurses, and to the care system. According to the Case Management Society of America and observation of our own limitations in delivering care, case managers who do not have a license in North Dakota or South Dakota, or any other states for that matter, do not have the ability to provide care or services to patients living in other states. Currently, to offer nurse case management services, the nurse case manager must have proper state licensure, recognized endorsement, or statutory waiver, which is really typically only seen with VA or military services. Without that special permission, a nurse may not be adhering to state licensure requirements, thus setting folks to be practicing against the law. In an article comparing the discipline between nurses holding a multi-state license, and this goes to Rebecca Foch's point, the overall discipline rates for nurses in the nurse license compact state and non-nurse license compact state were virtually identical. A further breakdown of this data reviewed that the discipline rate for nurses who had multi-state licenses was extremely low, even lower than those within each individual state. So the conclusion is that multi-state license holders consistently low discipline rates holds true across all available demographic categories, suggesting the overall safety of a nurse licensure compact. This dispels any concern about nurse safety being of concern considering that nurse licensure agreement. I thank you for the time to testify today.
Thank you. Next, we have with us Patty Williams. And I was looking up and down the list. Is anybody? Patty Williams, are you with us?
Here.
Okay.
Okay, I'm here.
I saw the one telephone number there, so that's great. Please identify yourself for the record, and then please continue with your testimony.
Okay, I'm Patty Williams. I would like to greet everyone. Good afternoon, Chair Utke and the committee members. I'm from Pingilly, Minnesota. I'd like to thank you for a few moments to allow me to speak with you regarding the Nursing Licensure Compact, which is of great importance to me and my husband and the health care he needs. My husband, David Williams, is 82 years old and has been my best friend for over 56 years. He has multiple health concerns besides his stage 4 kidney disease. He has suffered a major stroke, has also had TIAs. He has celiac disease and its related Renault's phenomenon. He's got scleroderma and is in early stages of dementia. It is very important to us to be able to share results from his medical testing done here in Arizona with our trusted and involved care team in Minnesota to receive their feedback so we can have continuity of care. With his multiple health issues, our harsh Minnesota winters are difficult for him, and the warmth and sunshine here in the desert make him more comfortable. His doctors here in Arizona are good, but don't know his whole history. Also, the protocol for prescribing medication to treat his hemoglobin, which causes his anemia, in Arizona different greatly from what David requires, while Dr. Davity and Elise, his Minnesota care providers, know just how to treat. It is imperative that we have their expertise in his treatment to help me care for him. I feel we deserve this shared communication and quality of care no matter where we are and with no disruption. I'd like to thank you again for giving me the time in this very important matter. Please contact me for any further information. For these reasons, I ask the committee to consider Senate File 2302, and I'd like to again thank you for your time and consideration.
Thank you. Next, we have with us Elise Crowley via Zoom. Welcome to our committee. Please identify yourself for the record and then proceed with your testimony.
Hello, thank you very much, Chair Utke and committee members, for listening to my testimony today. My name is Elise Crowley, and I am a registered nurse at Essentia Health in Duluth, Minnesota. I've been working for the last 2 years in the nephrology and infectious disease departments. There are many reasons why I believe Minnesota should join the Nurse Licensure Compact, but the one I think is most important is centered around patient care. For the nephrology department, most of our patients are elderly and often spend winters in warmer climates. Because Minnesota has not adopted the compact, I cannot continue to care for my patients that leave for the winter without obtaining additional nursing licenses, which is difficult to maintain because of the substantial costs. This is especially true for snowbirds that have chronic kidney disease and suffer from anemia. To manage this condition, these patients are prescribed Aranesp injections, which stimulates red blood cell production and increases hemoglobin levels. This medication is taken on a long-term basis, and it is very important that this therapy is not interrupted to ensure proper management of hemoglobin. When anemia is not treated correctly, patients can experience fatigue, dizziness, difficulty breathing, chest pains, and may ultimately need a blood transfusion, which we want to avoid as much as possible. I want to tell you about one of my nephrology patients who is currently prescribed Aranesp therapy once monthly. While he and his wife were in Minnesota, I would make sure that he went to the lab once a month, and based on his hemoglobin results, I would let his wife know whether he could receive the injection as required by the parameters we follow. Because there are risks of adverse effects if this medication is given when hemoglobin levels are too high, being able to conduct regular lab monitoring and check-ins with the patient is absolutely critical. Unfortunately, now that the patient is in Arizona for the winter, I am no longer able to properly monitor or check in with him because I do not carry an Arizona license. This in turn forces the patient to either receive care from a new nephrologist or to discontinue therapy until the patient returns to Minnesota, which would not be advisable. The patient has tried to establish a new nephrologist, but because of differing practice preferences, Arizona-based nephrologists will not prescribe Aranesp unless the patient's hemoglobin is below 10. This differs from the patient's Minnesota therapy plan, which is designed to keep his hemoglobin levels between 10 and 11.5, because he experiences significant symptoms when his hemoglobin drops below 11. As you can imagine, this is a very distressing and confusing situation for the patient and his wife. Simply stated, if Minnesota adopts the Enhanced Nurse Licensure Compact, I would be able to continue to help safely manage the patient's Aranesp injection therapy while he is in Arizona without the financial burden of maintaining numerous nursing licenses. For these reasons, I respectfully ask for your support of SF 2302. Thank you very much for your time today.
Thank you. Next up, we have Martin Dempsey. Welcome.
Good afternoon,
Yvette.
Chairman
Thank
Ike,
you. And
members of the committee. My name is Martin Dempsey, and I am serve as the Midwest Regional Liaison for the Department of Defense under the Secretary of Defense for Personnel and Readiness. Thank you for allowing me to be here today. Our mission is to resource policymakers in their work and address quality of life issues for service members and their families. And this bill, Senate File 2302, does that. It eliminates the encumbered process for licensing and streamlines the process to make it a seamless transition for family members that hold nurses licensing. Currently, our spouses that are licensed number 53% currently on active duty. Of that, 68% of our military families report that their spouse's ability to maintain a career depends directly on their ability to reenlist and stay a career soldier service member. And I don't need to tell you, this impacts us dramatically with our force and our ability to maintain our readiness. Today, we have 8 compacts that we're working because the Department of Defense believes compacts are the future. Gone are the days where we had our mother and father start a job in their 20s, and 40 years later, they retired from that very same job. We live in a mobile society, as alluded to in previous testimony. Often 2 to 3 years at a time, we change jobs. That's certainly the case in the military. Maximum usually about 4 years before they're on to a new job. Some of our spouses have reported it's been up to 6 months while waiting on a license to be secured and start their career. I don't need to tell you the impact that has on a family that's used to, and needs 2 paychecks to go 6 months without only one paycheck. This compact, as I said earlier, is the 21st century way to do things. The 8 compacts we're working, which is going to be 14 next year, is the way that we think we're going to take care of those military members with your help. Minnesota would also benefit from this by having those service members serving outside the state be able to come back into their state with a seamless transition again, should the service members decide to separate. And that's the first thing service members do usually, is look at their home state and see how easy it is or the benefits they have in their home state to seek employment. And unfortunately, they usually seek the path of least resistance. And that is the most unencumbered way to seek that employment. Senate File 2302 is a tremendous step forward for Minnesota to ease the burden for our licensure for military spouses, our military members, and our veterans. We appreciate your consideration. In closing, we hope you'll find favorable on this issue. And when you're ready, I stand ready for questions. Thank you.
thank you. Okay, next up we have Dr. Connie White Delaney, and she's going to join us at the testifier's desk. Welcome to our committee, and like the others, just please identify yourself for the record and continue with your testimony.
Thank you, Mr. Chair and committee, and thank you for the opportunity to speak with you. I'm Dr. Connie White Delaney. I have the opportunity to serve the land-grant University of Minnesota School of Nursing as Dean. The School of Nursing is one of the largest, top-ranked, comprehensive schools of nursing in the nation, ranked among the top 5%. We are in full collaboration and partnership with all schools of nursing in our state. And I'm a lifelong Midwesterner and a strong rural affinity, as a farm girl, actually. And I'm here to talk about why the Nurse Licensure Compact is vital not only to our university, but to the higher ed institutions, schools of nursing in this state, and our students and our graduates. The support for the Nurse Licensure Compact, we've heard many times over, is alive and well and successful in 39 states. It's modern, flexible, dynamic. It's the model for nurse licensure in a modern society. Minnesota functions under a 100-year-old nurse licensure model. It's not flexible, adaptable, nor nimble to address the needs of Minnesotans, our nursing education programs, and modern healthcare delivery. So you and we know the facts. I'm not going to repeat them. We've heard about the 20-plus year history. We've heard about criminal background checks. We've heard about uniform licensure. We've heard about respect for Minnesota practice laws, and we've heard about discipline. Sometimes people raise the question about nurses who come to Minnesota under the Nurse Licensure Compact and whether or not they are as safe as Minnesota licensed nurses. They are. A study that is online now and you'll see in print in April, 2 months from now, it's a national study that's reported in the Journal of Nursing Regulation, and it basically documents that the annual discipline rate of nurses holding multi-state licensure is almost one half of the rate of nurses in non-nurse licensure states. All educators in our state, in our nursing programs, are committed to helping you address the most dire, severe nursing shortage this state has most likely ever experienced. All of our graduates complete our programs, which must and do meet national standards for quality and best practice. And all of our graduates are prepared to practice within a nurse licensure compact. You heard comments before me that talked about the 2022 data, Minnesota data, that show us that right now, over 24% of our nurses are already providing services to patients outside Minnesota. Our graduates are prepared to support that care. However, under this antiquated nurse licensure model, a nurse must get a license in every other state to provide, for example, telehealth care, because Minnesota nurses do not have the multi-state license. Our largest nursing program member organization, AACN, has endorsed the Nurse Licensure Compact since 2013. But you know, there's more to the story. Our ability to more fully address the nursing shortage is hampered by the availability of clinical training sites. All of our nursing programs in the state of Minnesota partner with every health system in this state. And yet, we must expand beyond the borders of this state. Simply put, there are not enough clinical training slots in our state to serve the students. What this really means for today's discussion is because we are not a nurse licensure compact state, every professor or clinical instructor, whether for one student or several, has to secure a license in each state where they supervise clinical experience for the students. The process is slow, it's costly, it's inefficient, and frankly constipated. Support for the Nurse Licensure Compact will enable us and our nursing education programs, in partnership with our health systems, to increase access to care, leverage safety, efficiency, and excellence of telehealth, help us be better prepared to immediately respond to health crises, service our military individuals and families, the list goes on. We ask that you enable us, in partnership with all of our health systems in Minnesota, to serve patients and families beyond our state boundary. The time is now for you to support Minnesota schools of nursing, our students, our graduates, and our Minnesota nursing workforce. The time is now for you to support the health of our people of Minnesota with a modern, collaborative, dynamic, flexible model of nurse licensure, the Nurse Licensure Compact. And the time is now for you to support the nursing excellence that already exists in this magnificent state. All of our schools of nursing already meet national education standards, and we have a national licensure that supports nursing practice in today's modern health systems. Thank you.
Thank you. And next up, we have Val Riley.
Sure.
Welcome to our committee. You were, sorry to interrupt you. Go ahead. You knew the drill, right?
Number 11.
Yes.
Well done. My name is Val Riley, and I am speaking today on behalf of Fresenius Medical Care, and also as a registered nurse. Fresenius operates 52 outpatient dialysis facilities across the state of Minnesota, and we provide life-sustaining dialysis therapy to 2,400 Minnesotans by over 600 caring individuals. I'm a registered nurse who relocated back to Minnesota approximately 10 years ago. I'd had a career in the military and was living on the East Coast and came back to take care of my mother, who had been diagnosed with dementia. My original state of licensure was Virginia, and I was unable to use my compact licensure in Minnesota when I came back to Minnesota. I also hold licenses in Wisconsin and Virginia and Minnesota, 3 active licenses, all of which I pay nursing fees for every other year to the tune of several $100s. I'm a little nervous.
Doing great.
Prior to COVID-19, Fresenius averaged 14 RN openings across the state of Minnesota, and at any given time. At the beginning of this year, our RN openings rose to 29 openings. Currently, it takes us approximately 80 days to fill an open position, which is double of what it was prior to COVID. Dialysis nursing is a specialized field, and Fresenius relies on being able to mobilize fully trained dialysis nurses during times of staffing crises. And I think that we've all seen that during COVID. And the Center for Medicare and Medicaid Services has strict regulations about who can care for dialysis patients in outpatient settings. And they require only dialysis experience for those nurses that are caring for those patients. We operate clinics across the country, and we rely on being able to mobilize staff around quickly to help in staffing crises. The Nurse Licensure Compact helps dialysis patients by improving their access to quality and timely services. During COVID, the issue of access to care became particularly acute, as we all know. When COVID surges occurred, the ability to bring in qualified out-of-state nurses was critical for dialysis clinics and hospitals to provide life-sustaining treatments for our patients. An additional benefit is the ability to provide telehealth services to dialysis patients. Nurses may provide these services for dialysis patients located in multiple states. Finally, more patients are dialyzing independently at home. A compact license allows nurses to continue to provide services if a patient travels out of state and needs nursing advice while dialyzing in a different area. For these reasons, I ask for your support for SF 2302. Thank you.
Thank you. Members, at this point, we would take questions or comments for the first 11 testifiers or the author up to this point. Anybody got anything they want to answer or get answered? If not, we will take and we'll continue with our testify. Oh, sorry about that. Senator Wickland.
No, I have a question for the author. I wondered if Senator Nelson could tell us how would, if Minnesota, if the legislature decided that it needed to make a change in the nursing standards or training requirements or some other item, how would we go about doing that if we were a part of the Nurse Licensure Compact?
Senator Nelson.
Oh, thank you, Mr. Chair. And Senator Wickland, thank you for the good question. There would not be a change in that Minnesota nurses are already trained to the national standards that are the enhanced Nurse Licensure Compact standards. So our nurses are trained and ready to go. They would qualify under the Enhanced Nurse Licensure Compact. And in addition, of course, there are, of course, the background checks as well. So Senator Wicklund, our nurses are ready to go. We are holding them back. Our antiquated law is holding back getting qualified nurses to the patients that so desperately need them.
Thank you. Senator Wicklund, a follow-up?
Mr. Chair, yeah, no, what I'm asking though is what if we in the legislature are presented with a case where we need to change the nursing standards if you're a part of the Nurse Licensure Compact, how does an individual state have an ability to make any changes to what they see as a requirement or a needed requirement?
For this. Senator Benson, were you going to jump in on this question?
Thank you, Mr. Chair. And Senator Wicklund, if we were going outside the national standards, I think that is something that we should look at very seriously, because we'd actually be putting at risk the process by which our nurses receive their RN standards. There is national accreditation for our nursing schools, and there is a national board test that is required for you to be an RN. So if we were going outside those standards, which are included in the Nurse Licensure Compact, I think that would be a very grave decision. I don't think the Nurse Licensure Compact would be the primary impediment.
Senator Wicklund, did that answer your question?
Well, not really. I mean, I wondered if there is a process for it. I mean, what if the state decides that there is some compelling reason that we feel we need to? Is there a process? I guess I'm asking, is there a process for doing that if it's determined in the future that is needed, and there are, all the other states that are participating in the compact? Is there any method for a state to do that?
Yes, we have Dr. Delaney join us. I think she's got the answer.
Thank you, Chair. This is an excellent question. And in fact, congruent with all the other comments that have been made about the national accreditation for all of our programs, the national licensure, if it happens that the state of Minnesota makes changes in the nursing licensure law here, for any nurse coming into this state, they still need to abide by the Minnesota law, even as part of the Nurse Licensure Compact. So the Minnesota rules would be respected.
Thank you.
Thank you. Thank you.
Okay, I see a hand up with Rebecca Fudge.
Sure, I was hoping to take a stab at that question. And Senator, Minnesota can change any of their licensure requirements or any of their practice standards within Minnesota. That the compact has no bearing on that. The only thing that Minnesota wouldn't be able to change would be the licensure requirements that are required for a multi-state license. Those are those 11 requirements outlined in the legislation. And that's because in a compact, all of the states are agreeing to essentially the same terms, like a contract. So one state can't unilaterally change the requirements that none of the other states have adopted. If down the road, let's say a decade from now, all the states come together, and I'm just going to throw something out there. Let's say that all the states believe that all nurses should be mastered prepared before they can be licensed as an RN. If all of the compact states come together and vote on that requirement and then pass that legislation at their state level, that could be a change in the compact. But no one state could say, now we are going to require our nurses to be licensed, to a higher to be educated to a higher standard. And the reason that the uniform licensure requirements are in the compact is not so much for states wanting to go above, but states, particularly now with a nursing shortage and desperate staffing shortages, they're there so that states don't go below. So you could foresee potentially a circumstance where a state is so desperate for nurses that they may want to not require the passing of the NCLEX, and that's that national exam that every nurse must take. That's something that while a state could do that, it would not be a part of the compact, and they couldn't issue a multi-state license without the NCLEX. So it's really there to make sure states don't go below, not that they don't go above.
Okay, thank you. Senator Abler.
Well, thanks, Mr. Chair. I was going to, that's on. I was going to wait to the end, but since we're having a discussion now, I don't want to take away from the testimony of other people, but, you know, I've had concerns about this for a long time, and it's just, I don't know, I appreciate the discussion. I appreciate all the piles of papers I've got. But so it seems like the bottom line is that there's a floor, and then there's a ceiling. It seems like Minnesota is a ceiling state, and some other states are floor states. I have relatives who live in Tennessee. They're grateful for Mississippi because it's number 50 compared to 49 in some of the statistics. And so that remains my concern. But I do have a question. One of the testifiers mentioned that if we had this, then people could go to Wisconsin and Iowa to work, which would be, I suppose, nice if you want to go to Iowa. That's probably a different hearing for a different committee, Mr. Chair. But does anybody know what the churn factor is? I think at the end, what I think, it's just a big leveling. So some people come here, they go there. And at the end, I don't know if we're going to really gain anything, even if we do this. But does anybody know that offhand? So, thank you.
I don't know, anybody? Senator Nelson, you have anything on that, or any of the testifiers that you know of that would be?
I will call up anyone who has additional information, but I will share the information that I have. I'm not totally confident about exactly what your question is, Senator Abler, but we do have 8,900 RNs and LPNs with non-Minnesota unencumbered licenses. I don't know if that gets to the churn factor, but
Senator Nelson,
yes.
I think you dialed a friend here too, so we'll see if she's moved.
No, actually,
Dr. Delaney?
this is exactly who I was hoping to see up at this testifying table. But to the churn factor, I would just say the most important thing is that the nurses are where the patients need them, which isn't always a static situation.
Go ahead if you want to add to that.
Thank you, Mr. Chair. This is a wonderful question. It gives us the opportunity to highlight that this isn't just about the present. This is about a sustainable solution for the state of Minnesota going forward. And from an educator perspective, what's happening right now is we're being hampered by our ability to serve applicants that come from other states to our nursing programs and do some of their clinical experience in other states. And why I say that is those very applicants could be our recruitment into nursing workforce following graduation, and also future faculty of our nursing programs in this state. So the pipeline effect here of having a nurse licensure compact in the educational environment, so longer term planning and ability to address this massive critical nursing shortage in our systems, in our faculty, is what we're trying to also affect.
Mr. Chair.
Yeah, Senator Abler.
I'm not going to belabor things. I just intended to speak a little today, and so, but we're talking discussion of the future of nursing and workforce and all that. I think that any discussion of that has to include just the challenging circumstances that nurses in the whole hospital, Senator Klein knows much more than I do about just the way it is, and the double backs and the unsafe circumstances, the whole idea of overload, and even sometimes not to question the motives of some of the bigger, health systems, but even that they're purposely understaffing. And then the strike comes and you bring in busloads of people from somewhere. And so I think that maybe this is a tool. I'm uncomfortable with it, but I think we just need to discuss more the future of nursing in general, and how do we retain anybody who wants to be a nurse and give them the opportunity to be professors and all that. So anyway, thank you, Mr. Chair.
Thank you. Senator Klein.
Mr. Chair?
Senator Nelson.
Dr. Delaney does have a comment to that particular issue.
Dr. Delaney, go ahead.
Thank you, Chair. Again, you're hitting on one of the most critical aspects of what we're dealing with. You heard our previous colleagues talk about how it is that we serve patients and families. We stay connected to them no matter where they're at. We try to stay connected. And that is one of the core factors that retain nurses and frankly combat burnout. When we can't stay connected to the patient and the family in that continuous service, that, if I might just say, undermines and cracks the very essence of what nursing is all about.
Thank you. Senator Klein.
Thank you, Mr. Chair, and Senator Nelson for the bill. I actually want to follow up on Senator Wickland's question because I felt like we got slightly different answers from Dr. White-Delaney and from Ms. Foch. And so I guess I'll ask the question of those same two testifiers with a very concrete example. Let's say in a future legislature we opt to require certain continuing medical education requirements for nurses in our state, which we may well do, require a education on opioids or on cultural competence or something along those lines. Is it the case that if we did that and it was different from other compact states that we would be in violation of the compact, or is it the case that we could impose those requirements and then nurses within the compact who came into Minnesota would be required to fulfill those obligations?
Senator Nelson?
Yes, I believe Dr. Delaney did answer that earlier. If you'd like to kind of add some more to that.
Go ahead, Dr. Delaney.
Yes, and I also very much support and welcome the comments from the National State Boards of Nursing. So the flexibility is there in a state. And as was stated, part of these, if you will, rules related to multi-state licensure ensures that we don't drop below the standard, which is not Minnesota's concern. That's not Minnesota's, but it frankly happens in other states. And so the idea is that if there are changes that are made in the state licensure law that, or in the Practice Act, that it can't change the rules under which the state of Minnesota signed on with the state licensure compact, which were accredited program, nursing, national boards of nursing, NCLEX, licensure. Yeah.
Senator Klein, that's good? Okay, thank you. Senator Eaton.
Thank you, Mr. Chair. I guess first I would start out by pointing out that there is a reciprocity agreement already in place between Minnesota and Wisconsin, Iowa, and both of the Dakotas, North and South. And so that issue is already resolved. And I just can't emphasize how all the people in support of this bill are people in management and supervisory positions and leadership. If we need to change the Practice Act in Minnesota, we can do that, but not instead of ceding control to the national level. The people who really have a problem with this bill are the bedside nurses. They're the ones that are getting us through this pandemic. They're the ones who are going to be impacted the most by this, and not the nurse managers. And so we need to support those who have been on the floor working with the patients, and that's who I trust, not the nurses, the ones saving lives, not the ones pushing paper. A vote in the favor of this bill is a slap in the face to nurses in this state. This is just another way to break up the unions.
Thank you. Senator Nelson, I think you want to follow up.
Yes, thank you, Mr. Chair. And I would urge the members to look in their packets, and I'll be glad to. I'm sure that Senator Eaton also has that in her packet. But I agree with Senator Eaton. We need to listen to the nurses on the front line. And that's what we did. If you look in your packets, you will see that the survey from the Minnesota Board of Nursing, this is a pretty, this is not, you cannot misunderstand this, folks. 78% of Minnesota nurses with an active license support the state joining the compact. Not, I would assume not only do they want to make sure that they can serve their patients, as you have spoken about in this continuous loop, or with telemedicine, or as in the neck of the woods where I come from, the needs of the patients always come first. I'd assume they'd also want other opportunities as well. So let us listen to the nurses on the front lines, and I encourage you to listen to their voice when 78% of them said that they support the state joining the nursing, the Enhanced Nurse Licensure Compact.
Thank you. Joining Dominic, did you want to add to that?
Yes, this is
Mr.
Dominic Paul here. And I wanted to articulate, I not only represent a nurse manager role, I also represent a staff nurse role. Throughout the course of the pandemic, I've made the choice to return to my critical care roots and work in our medical ICU caring for extremely ill COVID-19 patients throughout the course of the pandemic, an effort that I'm not compensated in addition for, but an effort that I chose to do so. And so I just wanted to make sure that it was understood that I'm not simply here to push papers or to speak on behalf of executive leaders in a healthcare system. I also speak on behalf of staff nurses that do work at the bedside, staff nurses that we should listen to. And as Senator Nelson clearly articulated here, 78% of our nurses would really appreciate your listening to this. So thank you all.
Thank you. And I think I don't see any other hands up or such. Okay. Ms. Riley, go ahead.
Okay. Thank you, Chair and committee members. I'd just like to say that I have been an administrative nurse for several years. When COVID hit, we skilled up and we've been in the clinics as the nurse on the floor.
It's true.
So we are staffing, and so I consider myself a staff nurse as well. And just a little of the statistics that I looked up prior to coming is that I am one of over 100,000 RNs in the state of Minnesota. And we're not here to bust a union. You know, my father was a union member. But there are 22,000 nurses represented by MNA. So there are 78,000 nurses outside of MNA that need representation and need a voice. And I'm one of those people. Thank you.
Thank you. And on Zoom, we have Kelly Hagan.
I just wanted to respond to Senator Eaton's question, Chairman Utke, if I might. And I know that you're calling out nurse leaders and leaders of organizations who are responsible for patient care. I do take that personally in that my mission and my only mission is to ensure our patients get the care that they need and that our staff have a great place to work. And by doing so, I need to support this compact licensure so that we can get folks in to ensure our patients get that care and to ensure our nurses are able to work in the environments that they need to take care of those patients. And so I just wanted to set that straight, that as a nurse leader, those are my priorities. They are not about everything else. They're about patients and they are about our staff. Thank you.
Thank you. I think now we want to make sure we move on. We've got 3 more testifiers on our list that we want to give a chance for them to have their time to present their message. So first up, we have Mary Turner.
Hi.
Okay, welcome to our committee. And please identify yourself and continue with your testimony.
I will. Thank you, Mr. Chair and committee. My name is Mary Turner. I'm an ICU nurse at North Memorial Medical Center in Robbinsdale, Minnesota. I'm also the elected president of Minnesota Nurses Association. In Minnesota, we are 80% of all the bedside hospital nurses in the state. And I'm here today in opposition of Senate File 2302, the Nurse Licensure Compact. We recognize that with current strains on our hospital systems due to COVID, the compact is assumed to solve these problems. But I and my fellow nurses are here to tell you today that it will not. What it will do is distract from the roots of our current workforce issues. First and foremost, it's important to recognize that there is no shortage of RNs in Minnesota. There are 120,420 registered nurses in Minnesota, and the number of RN licenses has increased over 13,000 in the past 5 years. As it always has been, nursing is a calling. My colleagues and I are called to care for patients at their toughest moments. So it's no surprise that the difficulty of the pandemic has inspired more Minnesotans to get their license. Rather, what we face is a shortage of nurses willing to work in unsafe conditions that jeopardize the health of their patients, their license, and their mental health. While at first blush, opening Minnesota to a multi-licensure system might sound like it would increase the number of nurses, a 2016 study of the NLC found otherwise. The study examined data on over 1.5 million nurses and found that a state adoption of the NLC has no positive effect on a variety of labor market outcomes, such as labor force participation, employment levels, hours worked, earnings, and the likelihood of working across state lines. M&A recognizes the acute pressure COVID has put on the hospitals. Surely, as nurses, we feel it every day. I know as a COVID ICU nurse for the past 2 years, I feel it every day. However, there are workforce shortages across the country. Nearly all of the states included in the NLC have documented shortages. In January, after investing $40 million into the emergency staffing pool, the state has still not met its target goal for nurse recruitment. It's simply because shortages exist everywhere. And for those nurses who were recruited to Minnesota to work, they were able to start working in Minnesota hospitals within about a week. This demonstrates that our current process works swiftly to get out-of-state folks working in our facilities. Despite all of this, our core concern about the compact is one. You've heard from us for years now. We are concerned about the impact on patient care. M&A believes that nurses everywhere, whether they practice here in Minnesota or in Mississippi, care deeply about their patients. The only difference is that Minnesota has a long history of investing in the nursing profession and lifting up licensure requirements. Did you know that the first nurse registry was founded in Minnesota and that we are home to one of the first nursing practice acts? It was meant not only to formalize the nursing profession, but also to protect patients by ensuring that they receive exceptional care. It was also meant to provide oversight. The compact takes the control of licensing requirements away from the individual states and elected officials, putting it in the hands of an interstate commission headquarters out of a DC office. Changes to licensure procedures and requirements would be made by this commission, in which Minnesota would only have one vote. Even if Minnesota opposed a new policy, we would be forced to submit to whatever standard was adopted. It could mean lesser trained nurses caring for patients, your elderly parent, sick child, injured spouse, resulting in an inconsistent level of care. The Nurse Licensure Compact is not a solution to the short-term workforce issues we face. Instead, it could have a lasting and devastating impact on patient care and the nursing profession in Minnesota. Please vote no on Senate File 2302. Thank you for your time.
Thank you. Next up, we have Wendy Wall. Welcome, Wendy. And I think you also, you've been with us, so you know the drill. Please just identify yourself and you can continue.
Thank you, Mr. Chair and members of this committee for taking time to listen to my testimony. Good afternoon. My name is Wendy Wall, and I am a bedside registered nurse employed at Sanford Health in Thief River Falls. I've been a nurse for 19 years, mostly working small town ICU med surg and I currently work in the emergency department in a town of less than 10,000. Nursing has never been a profession for the faint of heart. We expect to work hard. We give our minds and hearts to our work. It is hard, but it is also incredibly rewarding. The honor of traveling with patients and families as they walk through some very difficult journeys, walking with them using my nursing knowledge and compassion to take them to their best destination, that is why I am a nurse. Bedside nurses expect to work some weekends, some holidays. We understand that we may have to stay late sometimes, even missing family things if it's serious enough. But since COVID, it is different. We are expected to do more with less, and as nurses turn and leave the bedside because they have given all they can give, I hear more and more nurses saying, "I'm done." They are contemplating leaving a career that has been their passion, and as more nurses leave, it only gets worse. We had 3 nurses leave the acute care bedside in this last schedule. Not only are we physically exhausted from working in these conditions, we feel disrespected, and it's taken a toll on our mental health as this seemingly never-ending pandemic persists. It has also taken its toll on our families. Nurses are leaving the bedside, and as we walk away, it seems the question is not why are they walking away and what can we do to make them stay, but instead seeking to replace us with temporary out-of-state workers. I believe the Nurse Compact won't solve the issues, and I believe it will have unintended consequences for communities like mine, the ones that are small but strong, the ones not based on tourism, the ones that don't have beaches or mountains or amusement parks or extensive shopping, the ones that travel nurses would see on a map and not think to explore, especially in a Minnesota winter. With the nationwide shortage of nurses, many of the critical access hospitals, like the one I work at, do not have draws in their communities to bring travel nurses. In fact, the hospital has had a posting for a travel ICU nurse since January. There has not been any applicants. I did, however, watch as 2 nurses on the critically short ICU team left the hospital to travel, as did the OB manager. The Nurse Compact is a two-way street. It doesn't just mean that nurses can come to Minnesota with a multi-state license. It means that nurses can leave our state and our communities for other places. Nurses may leave for better pay or benefits. Right now, travelers are making hundreds of dollars an hour, or they might leave for sunnier skies and warmer weather. And other nurses will remain embedded in communities, but will explore telehealth jobs when they can no longer bear the crisis bedside nurses currently find themselves in. In the end, it means our hospitals are still understaffed. I think we would all agree that the inpatient healthcare system in Minnesota is sick. We all know that we must do something. However, prescribing this treatment is going to make Minnesota's hospitals' chronic illness worse. This is not a simple accounting problem. This is not an acute 6-week staffing crisis illness in Minnesota hospitals. We must treat the underlying disease, or it could be disastrous for healthcare in Minnesota. I do not believe the Nurse Compact will help, and actually think it will make things worse. Nurses can travel to Minnesota. They do it right now. This solution has many unintended consequences and does not really address the problem. We must maintain the state's right to set nursing standards, and we must seek solutions that are long-term rather than solutions that keep kicking the problem down the road 6 weeks at a time, hoping it will go away. Thank you again for your time, and I urge you to vote no on Senate File 2302. Thank you.
Thank you. Next up, we have Senator Benson. Were you wanting to? We'll get one more. Okay, thank you. Next up, we have Lisa Wilson. And welcome, Lisa.
Hi, thank you, Mr. Chair and committee members. My name is Lisa Wilson. I'm coming to you this afternoon after working 3 16-hour night shifts in a row this weekend. I got off at 7:30 this morning. To say that we're exhausted is an understatement. I'm a registered nurse in the great state of Minnesota and a member of Minnesota Nurses Association. I'm here to tell you why the Nurse Licensure Compact is not only bad for my profession, but it's bad for all Minnesotans. I went to nursing school in Arizona, where I practiced LPN and got my RN. And then I spent most of my 12-year career as an RN in Florida. Both of these states are compact states, so I have immediate experience with the NLC. After 9 years as a nurse in Florida, I moved back here to my home state, where I am a critical care nurse and ECMO specialist at Abbott Northwestern. I went through the process of gaining a temporary license as a pathway to full Minnesota licensure in order to ensure that my practice standards were up to the Minnesota standard. This took me about a week. This was not a difficult process. It wasn't a timely process, but it was a process that I think is necessary because to me it said, we care who we label the most trusted profession in the country. To say that the quality of nurse is based simply on disciplinary action is disingenuous at best. The first thing I noticed when I started my career here in Minnesota is how much more pride I felt in the work that I do because I was able to provide care that I've always wanted to and just haven't had the support of. I was able to work next to people, I am able to work next to people that share the enthusiasm and a culture of improving our profession, something I've never really experienced because it wasn't an expectation, nor was it a priority. The quality of nurse that is expected here in Minnesota is second to none. At Abbott, as a major institution in the region, we are nationally recognized for the care we are able to provide, something I attribute directly to the standards that the Minnesota Nurse Practice Act holds. As Senator Abler pointed out, we should remain a ceiling and not pander to the floor. Currently, Minnesota is able to ensure that the standards that are held today continue to stay the highest level possible. This is the reason that Minnesota is known for their excellent care. If we were to become part of the Nurse Licensure Compact, we no longer stand out. We're just one of them. Minnesota would lose the ability to control the standards that we expect from those who are taking care of our loved ones in their most vulnerable time. That is not something that I am okay with. I strive to be the best, and I depend on you to ensure that I'm able to do that. I also urge you to reject corporate healthcare's argument that there's a shortage of nurses and that the Nurse Licensure Compact will improve those conditions. As someone who has nurse peers around the country, as someone who continues to hold active licenses that are compact licenses, this is not a Minnesota problem, and this is not a problem that the Nurse Licensure Compact will fix. There is not a shortage of nurses. There's overabundance of nurse exploitation that we are simply no longer willing to tolerate. The Nurse Licensure Compact only will perpetuate that. It allows corporate healthcare to outsource Minnesota jobs to states and workers with lower standards like Mississippi, Alabama, Texas, and other southern states because they are willing to accept lower wages, because here they are still more, just to have basic rights like that of a safe, healthy work environment. As a nurse here in Minnesota, as a resident here in Minnesota, and as the daughter and family member to an aging population here in Minnesota, I ask you and I urge you to say no to corporate healthcare and the Minnesota the Nurse Licensure Compact, and support keeping nurses at the bedside, something that will actually improve the care I'm able to give and will protect our patients. Thank you.
Thank you. Now we'll go to questions, and I just want to note that we do have Jessica Nyman and Shannon Cunningham from the MNA also online, but they're just here to help answer questions if some do come up that we would need them for. So with that, Senator Benson.
Thank you, Mr. Chair, and I was wondering if Ms. Miller from the Board of Nursing would be available to answer a question, because we were told about reciprocity. If she could explain exactly how North Dakota nurses can work in Minnesota and Minnesota nurses can work in North Dakota, that would, I think, be helpful in understanding. And we do have some limited reciprocity, so I'd appreciate a follow-up opportunity, Mr. Chair.
Thank you. Ms. Miller, I do see you on. If you could join us, please identify yourself for the record, and if you could follow up with that question or the answer to the question.
Thank you, Mr. Chair and committee members. My name is Kim Miller, and I'm the Executive Director of the Minnesota Board of Nursing. And what I can share with you is, I believe what Senator Benson is referring to is the border state licensure agreement. And what that allows is for nurses who are licensed in North Dakota, South Dakota, Iowa, and Wisconsin, and are in good standing with those, with their licenses in those states. If they are willing to work, and they must be a resident of that state, and if they are working for an institution in the state of Minnesota, they can use their license from that state to work in Minnesota. The less, it's very defined and limited to, and there is no reciprocity. Minnesota nurses don't have that same opportunity than to work in North Dakota, South Dakota, Iowa, or Wisconsin using their Minnesota license. It's a one-way directional opportunity. The last time that I looked at numbers, it was less than probably 150 nurses in the state of Minnesota, or from outside states, that are using this ability to work in Minnesota.
Senator Benson?
Thank you, Mr. Chair. And I just wanted to note, Minnesota nurses can't then support patients in those reciprocity states. So it's not true reciprocity, it's just Minnesota has a one-way gate open for those approximately 150 professionals. So as we move into, and Mr. Chair, this is a comment, not a question, as we move into telehealth, remote monitoring, as we look at our medical device industry and how they're developing devices that will be Wi-Fi enabled in your home that can help a nurse understand what's happening as you manage your chronic condition, Minnesota nurses won't be able to follow up with patients in other states. And that's really a key point that is being missed. Yes, bedside nursing is absolutely critical, and we cannot be grateful enough for what they have done. But there is another part of nursing that is emerging with remote monitoring, and that is going to be an important part of healthcare going forward. And as Minnesota seeks to maintain excellence in healthcare, to be able to have appropriate follow-up with patients who come here for our expertise and then go to other states for follow-up is going to continue to develop. And we're going to need to empower nurses to care for patients in that way. And Mr. Chair, similarly, mental health. Kids came home from college during the pandemic, and if they were in a mental health crisis and had nursing support here in Minnesota and then went back to Indiana to go to college and needed follow-up nursing and follow-up monitoring, that nurse would have to get licensed in Indiana in order to continue being that supportive of that patient. So yes, bedside nursing will never be low on the tier of nursing skills, but nursing is also evolving, and we have to match technology and patient needs, and the Nurse Licensure Compact, I think, is going to help us do that.
Thank you. Any other, okay. Ms. Hagan, I see you on the hand up.
Yes, Chair Aki, just to support what Senator Benson was saying, I believe Elise Crowley from Essentia did talk specifically about this matter in taking care of a dialysis patient who crossed state lines. And the care to that patient was so utterly important, but we couldn't provide it being in Minnesota to that patient. And I think that's just something we really have to think about, and to support the different modalities of healthcare delivery. And yes, all of nursing is very important, but as care evolves, we need to be very conscious of the fact that we will be taking care of patients all over the United States of America, and we need to be able to impact their care and to continuously monitor that care and to have that continuity of care for those patients. Thank you.
Thank you. Senator Abler.
Well, thank you, Mr. Chair, and I appreciate the discussion. And actually, I think this is how a discussion should go. I think we've heard from a lot of people today, and I appreciate hearing the passion in their voices about caring for the people. And having a career in this business, I've seen it change a lot. It's gone away from the patient is everything to now I have to do what my corporate director says as a clinician in a big system. I'm an independent, so I can do what I think is the best. But I'm astonished in so many discussions where doctors and nurses working for, pick a company, really have to say the party line. And so healthcare has gone from a patient-oriented thing to more of a business. And that's not any surprise. Oh, write that down in the paper. But what I'm afraid of still, one person mentioned it, some wrote a note. What's happening is the disconnect at the level of operations, where nurses that are just totally beat up, their director is awesome, but the high manager says no. The high manager goes like, no, we're not going to get as many as you think you need. We're going to require you to be pushed too much. So it is a management versus the bedside, staff nurse, charge nurse, et cetera. And so I still remain concerned that I don't think much is going to change if we do this. And I think it's going to put a tool in the hands of some of those corporate health people to actually make things worse. So I could talk a long time, but I'm not. I tried to be not too expressive today, Mr. Chair, but I think that this is a bill for a different day. Thank you.
Thank you, Senator Abler. Any other? Senator Wicklund.
There, I think I'm unmuted. Thank you, Mr. Chair. I just wanted to make a comment. I'm assuming that we're kind of reaching the end of our committee time, and I have appreciated hearing from all of the folks that we heard from today and the various perspectives on this. And at this point, I'm not convinced that this is the right step to take that will lead to a positive impact on our patient care capabilities in Minnesota, and I'm not supportive of this bill. I really think that we need to work on addressing the issues that have been brought up by nurses today of, not being supported in adequate staffing, not being supported in being able to get necessary amounts of time off from working, as one mentioned, 3 16-hour shifts in a row. I mean, it's incredibly taxing over the last couple of years. And I think what we need to do is be looking at how can we make the environment more livable for nurses in our state and address, these concerns. And this bill today isn't the way to do that. So I also am concerned about the oversight that we, as legislators or the nursing board, would lose some of that ability in this case if this is implemented. And so with those concerns today, I'm not supportive of the bill. Thank you.
Okay, thank you. We'll go back to Senator Nelson to wrap up and then move your bill.
Thank you, Mr. Chair and committee members. I really greatly appreciate the good discussion today, and I want to just highlight a couple things as we close. Number one, I want to make sure that one of the things we heard over and over was our antiquated licensure system is really getting in the way of continuity of patient care. And including the burgeoning telehealth and device industries as well. So I think continuity of care is key. And I do want to just, we didn't talk as much about the long-term care facilities, which also rely on nurses. And I know this would be important to Senator Abler as he has talked about this much in his committee. I just want you to know, and the public to know, that 75% of our long-term care and assisted living facilities are limiting admissions due to workforce shortages. And according to the Minnesota Long-Term Care Imperative, there are 23,000 open positions in nursing homes and assisted living settings. And we know how these shortages have a profound impact on our entire healthcare system. Some of those are licensed nurses and our RNs, our LPNs, and our vocational nurses. And so clearly we have a shortage. Everyone in this hearing today, and I think everyone in Minnesota realizes we have a significant workforce shortage, and that includes a significant workforce shortage in our often life-saving health system. The Nurse Licensure Compact, to be clear, allows for nurses who meet the high rigorous standards of the national boards of those states that are also members of the Nurse Licensure Compact. It simply allows them to serve patients, to work with patients in the state of Minnesota. And I definitely would not be interested in anything that would tie the hands of Minnesota. And as you heard, Minnesota can continue to have additional requirements if so determined, if so chosen. But we should at least untie the hands of the 78% of Minnesota nurses currently with an active nurse's license who want to adopt the Enhanced Nurse Licensure Compact. We can do that. We should not be beholden to a 100-year-old licensure system that is increasing costs, that is keeping qualified, highly qualified nurses from being able to serve in our state with our severe shortages in nursing, in the nursing profession. And we also heard about how important this is in advancing the pipeline, members. Our education, our higher education training of nurses, being able to advance that pipeline so that those nurses who are trained in our excellent Minnesota higher education schools are able to practice in the state in which they have been trained. So, members, I encourage a yes vote. I do want to say two things I almost forgot. Lest some people think that this is a partisan issue, I want to make sure that we are aware of what's going on in the nation around us. The Pennsylvania State Nurses Association, which represents the Commonwealth's 224,000 registered nurses, supports the Nurse Licensure Compact. That's Pennsylvania Senate Bill 655. In addition, the New York governor, a Democrat governor, has not only support joining the Nurse Licensure Compact, she has included it in her budget. So, members, it is not a partisan issue. This must be an issue about what is best for patients and allowing our nurses to practice fully with their licensure. So I do have the A1 amendment if you're ready for that, Mr. Chair.
Yep. We did adopt the A1 amendment. So you're ready to move your bill as amended?
Yes, thank you, Mr. Chair. I would like to renew my motion that Senate File 2302 as amended be recommended to pass and sent to Finance.
Okay, thank you. Everybody understand the motion? Pretty clear and simple. All those in favor signify by saying aye. Aye. Opposed? No. Motion passes. Thank you, Senator Nelson.
Thank you, Mr. Chair.
Members, right now, just as we're looking forward, Wednesday, we don't have anything on the calendar, so we would have a day off unless something comes up really quick tomorrow. But then we will be back at it a week from today. So with that, we will stand adjourned. Thank you.